Assalamu alaikum and good afternoon from Malaysia. Thank you for joining this 32nd MedEd webinar on developing and conducting integrated OSCE. Let us look at the learning outcomes first. After attending this session, the participants will be able to explain the concept of integrated OSCE, discuss the differences between OSCE and integrated OSCE, explain the differences between unidisciplinary and multidisciplinary OSCE, discuss the rationale for preferential use of OSCE, construct valid and reliable integrated OSCE questions, and organize OSCE stations, integrated OSCE stations following prescribed rules. So these are 6 learning outcomes which we will inshallah achieve during this session. But before talking about the integrated OSCE, let me use first few slides to refresh our knowledge about the traditional OSCE. As we know, OSCE is an assessment tool, and it is based on the principles of objectivity and standardization. These two attributes are very, very powerful characteristics of OSCE, and these attributes allow the assessment of candidates' performance against standardized scoring schemes and by trained assessors. Objectivity predominantly depends on standardized scoring rubrics, which are used during OSCE, and it is the same trained examiner who is examining or assessing all the students by asking the same questions or same task. So that's how the objectivity of the OSCE is achieved, and standardization by using the same examiner, same questions, and same scoring scheme. The OSCE assesses performance in a simulated environment. This is another characteristic of OSCE, that it is not in a real environment, but it is in a simulated environment and at the shows level of Miller's pyramid. Now, if we look at the Miller's pyramid, there are 4 levels, and OSCE is at the 3rd level, at the shows level, because it is in a simulated environment, whereas the DOES level or the 4th level is a workplace-based assessment, which may be a long case, short case, or mini CX, where students are directly observed while performing clinical tasks. The descriptive definition of OSCE will give a clearer picture. It is, of course, a performance-based assessment. It is based on the principles of objectivity and standardization. The candidate moves in a circuit through time-restricted stations in a simulated environment, and the assessment and marking scheme is done by using well-defined criteria and standardized scoring schemes. The same assessors are used for every student, and these assessors are trained to assess the students in that particular examination. Why we need to use OSCE? This is an important slide in clearing the concept. A candidate's assessment in clinical skills can be affected by 4 factors. One is the patient's performance. We know those we have gone through the long case and short case. The cooperation of patient is very, very important. Examiner's bias, the views of the examiner, the level the examiner is expecting in the students, and the let's say the status, maybe examiner is tired at that time, a standardized marking scheme, and the candidate's actual performance. So these four factors: patient's performance, examiner's bias, marking scheme, and the candidate's performance. But actually, it should be the only candidate's actual performance which should give the grades. So the beauty of OSCE is that it reduces the number of variables by using the standardized patients, same examiner, and standardized marking scheme. Therefore, in a well-designed OSCE, the grades of the candidates should predominantly be affected by the performance of the candidate alone, with minimal effects from other sources of variance. And this is the real strength of OSCE, that it minimizes the effects of other variances, and the score is more or less reflecting the actual performance of the candidate. Recently or currently, more emphasis is being placed on the experiential aspect of training. And if there is experiential aspect of training, the assessment should be performance-based. And we know that the more effective and more accurate evaluation of students' performance is done in OSCE setting, because it is a performance-based assessment. So this is another strong reason of using OSCE in assessment of students. Having said that, there are a number of potential limitations of OSCE, and I'll summarize in the next couple of slides. Another point, the performance is affected by various candidate-related factors. The first four factors which we were discussing, three of them were not related to candidate, the patient's performance, the examiner bias, etc. But if we look at the factors which are candidate-related, so they include possession of knowledge and the student's ability to apply it in real-life situations, the kind of scenarios being used, the non-clinical skills like decision-making, teamwork, resource management, planning, and critical thinking. These are important skills, though non-clinical, but important skills for profession of medicine. The attitudes, environment, emotional state, physical state, and personality traits. Now, all these candidate-related factors are necessary to assess the performance of candidate. However, not all of these factors are assessed in a traditional OSCE. Another point, the complexity of the competencies being tested at different OSCE stations may vary significantly. Not all OSCE stations are testing the same level of competence, so this means that passing a particular station cannot be utilized or used to generalize the results. For example, a station on history taking cannot be equated to a station on assessment of, for example, CPR or cardiopulmonary resuscitation. The second point, the clarity of instructions given to examinees or candidates, as well as the perceived degree of learning needed to achieve the competency or level of competency being tested or evaluated, may differ among examiners. So examiners may not be looking at the same level of competence at different stations, and so it may vary from one station to another station. So such wide variations may influence the validity and reliability of the overall examination. The reason I'm mentioning these limitations of OSCE is not to say that we should not use OSCE, but point is that we should take care of these limitations when we want to use OSCE, because this is a very, very useful tool of assessment. So here is the summary of limitations of OSCE. Number one, it is in a simulated environment, which is not realistic. Imagine examining an infant in a pediatric ward compared to a mannequin or infant mannequin in clinical skill lab. As I showed earlier, it is at the third level of Miller's pyramid, whereas the best would be to look at the fourth level or DUS level of a Miller's pyramid. OSCE cannot assess non-clinical skills such as team working, resource management, situational awareness, leadership, or entrepreneurial skills. OSCE is assessed in compartments. There is a fragmentation and the performance without context. So it may compromise the holistic assessment of the student. It is not as standardized as it was perceived earlier, because now with the increasing number of students, we may be using multiple circles. That means that the same examiner is not examining all the students. So that compromises one of the pillars of OSCE. Mostly it is testing the skills and not the competence. Competence is actually the use of knowledge, skills, and attitude at the same time, but OSCE may not be testing all those components at the same time. Validity compromised at the cost of reliability. In OSCE, a lot of emphasis is given on the reliability. That's why the standardized marking scheme, same examiner, same questions, and it may to some extent compromise the validity. Distracting minute checklists. We know that the checklists are sometimes very extensive checklists are provided during the OSCE, and that the examiner is more worried about the checklist than the performance of the student. We need to train the simulated patients. Similarly, training of examiners is needed. And if we use high fidelity mannequins, they are very, very expensive, and their maintenance is also very expensive. It is labor and resource intensive. And most of the OSCE stations end up using the theoretical knowledge, which can be easily assessed in the written examination. And candidates experience anxiety, restless, and stress. Because there are multiple stations, so each station is actually increasing their anxiety and stress. Unsafe or unacceptable behavior of the candidate is ignored. It's not considered usually in the marking schemes. And the tired examiners may affect the judgment if the same examiner is involved from morning till evening. So there may be some effect in the assessment of the students. Here is a powerful statement. We are teaching students to deal with mannequins as live humans. I hope the graduates do not end up dealing with humans as mannequins. So that is one real danger in OSCE in simulated environment. So having gone through those limitations, as I said, the purpose of limitations is not to say that OSCE should not be used, but the purpose is to minimize the shortcomings and retain the benefits of OSCE. And for this purpose, some modifications were attempted, including a move from traditional assessment to workplace-based assessment, or mini-CX. Mini-CX is a direct observation tool like a clinical examination of long case or short case for assessing medical interviewing skills, physical examination skills, humanistic qualities, professionalism, clinical judgment, counseling, organization, efficiency, and overall clinical competence. By going through this statement, we can realize that mini-CX can overcome many of the limitations of OSCE, which I have just mentioned. It has been stated in the literature that 5 to 6 cases in mini-CX are enough for a reliable judgment of clinical competency to be made of each candidate. This means that each candidate should be assessed on about 5 or 6 cases. So this number of cases makes it a difficult feasibility. Due to the problem of feasibility, it is less likely that high-stakes examination, such as summative assessment, will ever be able to attain workplace-based assessment, such as mini-CX or DOPS, or directly observed practical skills. Imagine if we use 6 patients for each student, and there are 50 students, so we need around 300 patients. And even if we use the same patient multiple times, still we would need a huge number of patients. And this makes mini-CX as a difficult choice because of the feasibility, although the method of assessment is very good. So second option is integrated OSCE. And unlike traditional OSCE, where 10 to 12 or sometimes up to 20 stations are used, each having a different scenario or a mission or task, one integrated OSCE has 5 stations utilizing only one scenario or a mission. Now, this is the basic difference, and this would clearly tell us what is the difference between a traditional OSCE and an integrated OSCE. In traditional OSCE, there are a number of stations, and each station has a different task and a different patient, a different scenario. Whereas integrated OSCE, one integrated OSCE, we can say comprise of more or less 5 stations, and they utilize the same scenario or same patient throughout that 4 or 5 stations. So those stations are excuse me, can you mute yourself, please? Dr. Mahira, can you please mute yourself? Yes, thank you. So that's the one basic difference between traditional OSCE and an integrated OSCE, that in integrated OSCE, the stations are related and the same scenario is being followed. I'll go into the more details in subsequent slides. The benefits of this approach is for students to go through a more detailed and comprehensive problem-solving exercise, because we are using the same scenario, or same patient, or same problem throughout these 5 or 6 stations. So we are able to do a more detailed and comprehensive problem-solving exercise, and are able to assess student in more holistically. Integrated OSCE combines the currently used OSCE methodology with an integrated, informative, investigative, and innovative approach by using both virtual and standardized patients. So basically, we are still using the traditional OSCE methodology, but we are making some innovative changes in that to overcome some of the limitations of OSCE. The integrated OSCE program uses a scenario, for example, abdominal pain, back pain, or headache, and a standardized patient, and then creates a dialogue between trainee and standardized patient, and sometimes a virtual patient. There's another name, which is task integrated objective structured clinical examination, or TIOSCE, that's again a different name, but in fact it is an integrated OSCE. And in this, a modified OSCE of a single case. So single case is used in that set of OSCE station, which is developed to assess the attributes of complex clinical skills in fragmented but maintained continuum of clinical performance. Although the stations are different, but a continuum is maintained, a link is created, and thus it is demonstrated in multiple structured stations and rated as integrated professional judgment. Probably these points would be clear when I will go through an exercise shortly, an example which would explain what it actually means. Integrated OSCE may comprise of a total of 15 to 20 stations of 5 to 10 minutes each, and these stations are subdivided according to the subspecialty in 3 to 5 stations, mean that each integrated OSCE may have 4 or 5 stations. Each integrated OSCE, that is a set of 3 to 5 stations, is an integrated problem-solving exercise. And we know that problem solving is a logical, analytical, and systematic approach to establish the cause of patient's problem, that is the diagnosis, planning treatment, that's the therapeutic management, monitoring the patient's progress and supervising the follow-up, convalescence, and rehabilitation. This means that by using integrated OSCE, we can assess all these attributes that leads to a holistic assessment of a candidate. Integrated OSCE may be viewed as a series of mini CX stations employed in summative assessment to test a candidate's problem-solving, analytic, and clinical reasoning skills as integrated performance over number of context-specific interlinked stations. If you dissect this statement, you will realize that number of OSCE limitations which have been mentioned are being overcome in this way. Or it can be viewed as a traditional long case split into number of stations, or a multiple part MEQ being made interactive. So for example, in a long case, we have the history taking, the physical examination, the investigations, etc. So same things can be tested in an integrated OSCE in different interlinked stations. Similarly, if you are familiar with multiple part MEQ, so we can make, this means that integrated OSCE makes those multiple parts as interactive sessions. Structured clinical tasks will be set at each station relevant to integrated OSCE clinical attribute. Tasks will be performed as asked by the assessor, are provided as short knowledge-based answer to various questions. That is the conduct of integrated OSCE stations. The interlinked station, which is 1 to 5 or 1 to 4, can be organized somewhat like progressive stages of modified essay questions format. Integrated OSCE can be organized as two different types of stations, static and interactive. In static stations, the candidate will be presented with patient data or a clinical problem as pictures, slides, video clips, or images to give written responses to questions asked. Whenever we are using these static stations, we should ask this question to ourselves. Do we need such stations? Can written examination assess the same aspect? So if it can be assessed in a written examination, that should not be part of the OSCE. Make sure that it is not simply assessing the theoretical knowledge. There has to be some kind of activity on each station. In the interactive stations, the candidate will have to perform a clinical skill or a procedure. For example, taking history, performing clinical examination, counseling, or demonstrating how to use an instrument. One examiner will be present at each interactive station with checklists to test analytic, clinical reasoning, and problem-solving skills like traditional OSCE. And that's how it differs from the static station. In interactive station, the candidate will have to perform some activity, and it has to be assessed by examiner who is present at that station. How integrated OSCEs are marked? The assessors will rate the performance of a candidate using a checklist with satisfactory or less satisfactory or unsatisfactory options on performance to reduce the subjectivity of evaluation. Here is an example. Yeah, you see the, okay, let me just show you, share that example. It's not here. Okay, I'll show towards the end that the example of a marking scheme and the using the satisfactory and less satisfactory and unsatisfactory options. Right. Now so apart from this satisfactory, less satisfactory, and unsatisfactory options, the global rating is also used, which is to give an overall assessment by the examiner using different categories, maybe excellent, good, pass, or borderline, or clear pass. A sum of marks obtained on a checklist will reflect candidates' performance for which standard setting method can determine the pass or fail criteria. So this is another aspect, important aspect of integrated OSCE, that a standard setting procedure is performed on each station to assess or to determine the pass or fail criteria. On stations where no examiner is present, the candidates will have to submit a written response to short answer questions. Now, what is the advantage or rationale of using integrated OSCE? We will talk about it in next few slides. To be judged as competent at clinical skills requires students to perform a particular skill as well as to integrate and demonstrate their ability to communicate knowledge effectively and to express emotions appropriately in a clinical setting like a proper clinician. This is one aspect which is missing in the traditional OSCE, but it can be addressed in an integrated OSCE, that it is not only the demonstration of skills, but it is the ability to integrate different attributes of competence, which is knowledge, skills, and attitude, and that helps to assess the students holistically. Realizing the problems associated with mini-CX, which I showed in the previous slide, because it is difficult to sorry, somebody is, yeah. So we know that mini-CX is difficult to apply because of the feasibility, because the number of cases required, and then the problems with the traditional OSCE being fragmented, so it may not enable examiners to make a valid and a reliable judgment on clinical performance of a candidate. And in this situation, integrated OSCE may provide an alternative method of assessment, both for OSCE and mini-CX. While retaining most of the favorable features of OSCE, integrated OSCE also addresses some of the limitations of OSCE. OSCE is criticized for fragmented skills of short duration stations isolated from each other, challenging its context, specificity, and generalizability across clinical context. And opportunity is provided in integrated OSCE to judge clinical skills in a range of contexts. So integrated OSCE can also overcome this problem, which we face in the traditional OSCE. So multiple stations with varying but integrated skills are a key to the success of integrated OSCE. As a solution to objective assessment of clinical competence, integrated OSCE is also comparable or superior to OSCE, which is proving to be less objective than originally supposed. And scoring against a checklist is not ideal. That's why the integrated OSCE uses overall assessment or global assessment, as well as the categories of satisfactory and unsatisfactory assessment. The overall reliability is improved in integrated OSCE with lengthening the time taken to evaluate problem-solving abilities of a candidate through a complex case, because we are using the same scenario for over 4 or 5 stations, so that increases the reliability. Sampling broadly across, excuse me, sampling broadly across the competencies to be assessed and increasing the number of examiners, as in OSCE, improves the reliability. However, performance tested in integrated OSCE, like an OSCE, is arguably not the same as the performance tested in real-life situation of a clinical environment. So this is another aspect which we need to understand, that OSCE or integrated OSCE cannot replace the DUS level or in workplace-based assessment or traditional long case or a short case. Validity, which may be compromised at the expense of reliability, as we mentioned that in traditional OSCE, a lot of emphasis is placed on the objectivity to achieve the reliability, requiring multiple cases and multiple examiners in a series of fragmented stations isolated from each other in OSCE is addressed by integrating the stations of clinical attributes of same patient or case in integrated OSCE. In this way, integrated OSCE actually overcomes the issue of fragmented stations which we face in the traditional OSCE. In traditional OSCE, there is a common complaint among the examiners that they do not play an active part in the assessment of students because they are simply observing and ticking the checklist. The satisfaction of examiners as they play a more active role in the assessment of students while conducting integrated OSCE as compared to OSCE, and also giving a global rating as compared to checklist. So there is more involvement of examiners in the assessment, and that is a factor which satisfies most of the examiner with their contribution. So far, we have revised our knowledge about the traditional OSCE. We have looked at the limitations of traditional OSCE, and then we have gone through the alternatives for OSCE, which is mini CX, but we see the feasibility problem with mini CX. And it seems that integrated OSCE may be a valid, reliable, and feasible alternative to traditional OSCE to overcome many of the issues which we face during traditional OSCE. So we will go through a bit more detailed of details of integrated OSCE. And first is the types of integrated OSCE, and I will give the detailed examples of these types. So integrated OSCE may be unidisciplinary, or it may be multidisciplinary. We have already mentioned that integrated structured clinical examination and task integrated objective structured clinical examinations are other names for integrated OSCE. The steps of developing an integrated OSCE, the first step is to identify the overarching objective of a particular integrated OSCE, because here we know that one integrated OSCE means 4 or 5 stations. So we need to have an overarching objective. For example, to assess a candidate's competency to manage an adult female patient with abdominal pain in an inpatient or emergency department. So this may be an overarching objective of one set of integrated OSCE. Number 2, choose an appropriate case or cases and prepare a summary. Best thing is to choose a real case and modify the scenario appropriate to the assessment objectives. Number 3, decide on number of stations and duration of each station. So maybe first station is history taking, second is physical examination and interpretation of physical findings. Third may be interpretation of provided investigation results. Fourth station may be management, procedures, demonstrations, or prevention or counseling. So in this way, one scenario would be covered in quite detail. Then the sequence of stations, then assessment objectives for each station. Now we had overall or overarching objectives for a set of for integrated OSCE, and because we know that each integrated OSCE may have 4 or 5 stations, so we need to have assessment objectives for each station. Then tasks for each station based on the assessment objective, for example, physical examination or demonstration of a procedure. Then scenarios, questions, model answers, marking schemes for each station. And then other important point here is to identify the must-know or essential components of students to perform in each OSCE. Next would be the instructions for standardized patients, instructions for examiners, instructions for the student. The equipment and personnel required for each station, for example, standardized patient, examiners, audios, videos, or the other equipment. The appropriate layout for each station, that how the student would move, the seating of standardized patient, the seating of examiner, procedure or demonstration. So I think all these points would be clarified by this example, which I'm going to quote now. And this is of a unidisciplinary integrated OSCE. So the first step, overarching objective. So for this, our overarching objective is to assess the competency of a candidate regarding management of a child with diarrhea and dehydration admitted to pediatric ward. So this is our overarching objective. Number 2, we need to prepare summary of a pediatric patient admitted with acute gastroenteritis. Number 3, we have to have the number and sequence of stations. So in this case, we will have first station on history taking, second on physical examination, third on interpretation of investigations, fourth on rehydration plan, and fifth on prevention of such episodes. So let's talk about the station 1. So objective of station 1 is to assess a candidate's ability or competency to take history from the mother of a child presenting with acute gastroenteritis. So scenario for this station would be, for example, Abu, a 14-month-old boy, was admitted to the pediatric ward of Hospital Shah Alam with the complaints of diarrhea and vomiting of 3 days duration. So this would be the scenario. Instruction for students: read the scenario carefully and then take history from the simulated mother to help you arrive at a diagnosis. So that would be the task. And then answer the questions asked by the examiner. So, and you have 5 minutes to complete your task. So these would be the instructions for the student. The instruction for the examiner: make sure that student has understood the task. This is very important because in OSCE, because students know they have a very short time. So they are rushing from one point to another, and in that they may not read their task carefully. So the examiner should make sure that student has understood the task. Student may not ask question exactly the way and in the sequence they are written in the model answer. So examiner has to use his or her judgment and discretion. And the questions to be asked for this station is: state the most likely diagnosis and state the most likely cause of the illness. The model answers are marking scheme. So noting that candidate may not ask exactly the same question in the same sequence. So examiner has to use his or her own judgment regarding that. So we do expect the student to ask questions about the onset, whether it is sudden or gradual onset, questions about the characteristic of diarrhea, a question about the characteristic of vomiting, then whether presence of fever, and whether there is history of contact or history of medication, and history of feeding, that means the preparation of milk and hygienic conditions, and past history of similar episodes. So these are our model answers, and we expect students to cover these questions. And for that, we will prepare this table of the 10 questions, and the examiner has to simply take yes or no if student has asked that question about the diarrhea and about the vomiting. Then at the end, the questions with and the student has to ask from the simulated mother, as we have mentioned earlier. So these are the answers which would be provided to the simulated mother. So when the student asks those questions, the mother would answer these questions. For example, students ask about the consistency of the stool, and mother would say it's watery, or whether there is presence of mucus or blood, and the mother would answer no, because we have to have these model answers to arrive at a diagnosis which we want students to answer in response to our question. So questions to be asked by the examiner and the model answer. The question would be state the most likely diagnosis, and then answer would be acute gastroenteritis. And then the second question state the most likely cause of illness, and the answer would be a rotavirus. This is based on the model answers which the simulated mother would provide to the student. So again, this would be a table where examiner has to simply tick right or wrong whether student has answered that question. The equipment and personnel required for first station would be, of course, room with table and chairs, simulated patient, which would play a role of mother, assessor and examiner, instruction for simulated patients, including questions and answers, instructions for the assessor, and scenario for the student, instructions for the student, task for the student, and marking scheme sheet for examiner and the model answer. So this would complete our station 1. So in this way, we prepare the station and conduct. Now going to the second station, here the objective for second station is to assess a candidate's ability or competency to perform physical examination of a child with acute gastroenteritis to assess the degree of dehydration. So station 1 was based on the history taking, and station 2 is based on the physical examination using the same scenario, and that's how integrated OSCE differs from the traditional OSCE. If you see, the scenario is same. Abu, a 14-month-old boy, was admitted to pediatric ward of Hospital Shah Alam with the complaints of diarrhea and vomiting of 3 days duration. Now here, the instruction to the student would be read the scenario carefully. Task would be performing the physical examination to assess the degree of dehydration in this patient, right? Whereas the task in the first station was to take the history. Then answer the questions asked by the examiner, and again, it's a 5-minute station which student has to complete. Instructions for the examiner: make sure that student has understood the task. Student may not perform the physical examination in exactly the same sequence as it is written in the model answer. So examiner has to use his own judgment or discretion. And questions to be asked would be the state the most likely degree of dehydration in this child. So again, following the same pattern, the model answers and the marking schemes. So we would expect the student to perform the physical examination to assess the degree of dehydration in this patient. But there may not be a real patient, there may be a simulated patient or a mannequin. This means that we would be actually looking at the technique of physical examination. So candidate demonstrates the technique of physical examination, what signs to look for and how to elicit the signs. Here, the model answers, we would expect the student would comment on the general appearance, active or lethargic, conscious level, respiratory rate or distress, sunken eyes, dry mucous membrane, and the depressed anterior fontanelle, skin turgor, pulse rate and volume, and the blood pressure. So this is what is expected of a student at this station. And based on that, the marking scheme would be prepared, and the examiner again has to take yes or no. And then the physical examination and model answer for the simulated patient. So here, because there is a simulated patient, so the physical findings may not be there. So when the student checked that for that physical examination, the finding would be provided. For example, the student wants to check the conscious level, so answer would be provided that the patient is drowsy, or the skin turgor is more than 2 seconds. So in this way, the findings. So basically, what we are looking at is the technique of physical examination, but the findings are being provided by the examiner. So questions to be asked by the examiner and the model answer to state the degree of dehydration, and based on the answers provided to the physical examination, the expected answer would be severe dehydration. And this would be the answer sheet where examiner would take in the right or wrong box. Again, the same list on the equipment required for station 2 as for station 1, and the if some because there would be scenario although same, but the instruction to the student and instruction to the examiner would be different, so would be the model answer. So this would be the station 2. Now coming to station 3, so it would start with the question, what are the most urgent investigations you would request for immediate management of this patient? Give one reason for asking each investigation. If you see, we are following the same scenario, and now we are moving on to the third station, which is based on the investigation. So first question would be examiner asking the students what investigation you would do, and this is the model answer we are expecting. And once the student has given the answer, the examiner may provide results of one or more investigation and ask the student to interpret the illness of the patient. So these are different investigations and their results which may be provided to the student to interpret. And then they explain the mechanism of abnormalities, and the model answer would be provided. And the activity here, now one may say that so far has been mostly the theoretical, but the activity here would be to explain to the mother the condition of the patient, that the patient is having severe dehydration, and what need to be how the patient need to be taken care of. Now, then we move on to the fourth station, still following the same scenario. And what was the it would start with the question again, and the examiner would ask the student, what was your answer for degree of dehydration and type of dehydration in this patient? Because student has already answered these questions on the previous stations, and they have been assessed on that. So if student gives a wrong answer, the examiner would provide the right answer, because student has already been marked on this, and we do not want to penalize the students multiple times for the same mistake. And the task would be based on the degree of dehydration and type of dehydration. And we will provide, the examiner would provide the weight of the child. So the candidate has to plan the rehydration plan and calculate the fluids. So plan the management, resuscitation phase, replacement of deficit, maintenance of fluid, replacement of ongoing losses. Note, if student does not give the right answer, 4 aspects of management of dehydration, then mark accordingly and provide the right answer. So here you will see that it resembles the multiple part type of MEQ, where subsequent parts of MEQ provide the right answer to pull back the student to the right track. So calculate the volumes of fluid to be given in each phase. So in this, that would be the real activity on this station, where student would calculate, and then they would choose the type of fluid and the how the fluid would be administered, and then the final station would be counsel the patient's mother to prevent such episodes in future, and again the model answer would be provided. So this is a unidisciplinary type of integrated OSCE, where the only one discipline, for example, pediatrics, has been involved, but all the 5 stations are using the same scenario, and the detailed and the comprehensive assessment of student has been done on that particular issue. Now, going to the multidisciplinary OSCE, I'll give few examples here. Here, for example, the first station is obstetric and gynecology of a simulated patient, and history taking from a pregnant lady who has poorly controlled gestational diabetes mellitus. Station 2 may be using a mannequin or simulated patient, demonstration of basically mannequin, demonstration of difficult delivery, because the mother is having diabetes, so there is the macrosomia, and that would lead to difficulty in delivery. So third would be, so first 2 stations are ONG. The third station would be combined ONG and pediatrics, and resuscitation of the newborn and the intubation skills would come here. And fourth would be pediatrics. Again, the newborn need to be monitored closely for hypoglycemia, and task would be to draw a monitoring or action plan and explain to the mother, the simulated patient, why newborn needs to be monitored in pediatric high dependency unit. And the fifth would be again ONG and simulated patient, and counsel the mother about the future pregnancies. So here you see this is multidisciplinary in the way that the 2 disciplines are involved, the pediatrics and obstetric and gynecology, but it is the same scenario being followed throughout the 5 stations, and all the assessment tasks are related to the same scenario. The other examples could be motor vehicle accident followed by panic attacks. So that would involve the emergency medicine, orthopedics, and psychiatry. Or a diabetic foot scenario on diabetic foot may involve medicine, surgery, and dietitian. Scenario based on backache may involve orthopedics, neurosurgery, and psychology. So these are the examples of multidisciplinary integrated OSCE. And basically, we, as you might have realized, we are still following the principles of traditional OSCE, but making it more integrated and using one or more disciplines at the same time to overcome some of the problems which we face in traditional OSCE. With that, I come to an end of this presentation, and I would be happy to answer any questions. Thank you very much for your attention. Yes, open for questions, please. Yes, Professor, sir. Aslam sir.
Thank you very much for seeing and listening to you after a long time. My question is very basic and simple. So far, we learned iOSCE as interactive OSCE. Today, we have known that it is integrative OSCE. So what are the basic differences between interactive OSCE and integrated OSCE?
Basically, I think both are based on the same principle. Now, interactive OSCE may be just one station where there is an interaction between a student and examiner. But integrated OSCE is a series of stations, 4 or 5 stations. They are all interactive, but they are linked together. So right. in this way, the one scenario is followed through in detail, and student can be assessed holistically rather than just one aspect. Basically, if we see closely, it is dividing a long case into different parts.
Right. So yes. It mimics in theory with the dependent questions.
Yeah, it overcomes the dependent questions. It overcomes the dependent, because each station is independent station. So whatever student has answered previously, that does not affect the subsequent station.
Right. Great. Thank you very much, sir. Thank you.
Right. Amir Ijaz, please.
Okay. Thank you very much, sir, for such an excellent presentation and enlightening us about a new assessment tool. I have 2 comments. One is that by doing this integrated OSCE, the feasibility of OSCE increases because we need less patients, we need less scenarios. And the second advantage, I think it increases the depth of the knowledge. We can assess one condition in more increasing depth as compared to the usual OSCEs. But there is one problem with this. A major disadvantage of integrated OSCE is that the content coverage is less, because when you are put 5 stations of simple OSCEs, you can assess 5 different areas, whereas in integrated OSCE, you assess only one area, but more depth. Thank you.
Sir, it is like you can say multiple choice questions of true, false, and a multiple choice question of single best answer. So basically, by using different OSCE stations not linked to each other, we are doing fragmentation. We are not testing the patient holistically, whereas this integrated OSCE covers that aspect. So similarly, in, for example, multiple choice true false type of questions, we assess many areas, but that is mostly the low level of assessment. So in this way, by integrated OSCE, we are going to assess a student more thoroughly and more holistically, and some of the aspects which were missed during traditional OSCE are covered in this way. So these are some advantages, and at the same time, we are maintaining the benefits of traditional OSCE. Yes, sir. Professor Laikuzaman, please.
Assalamu alaikum, sir. As always, a presentation, I must say. I had a question similar to the last question, but I also see an answer by myself. It seems that most of the times we, the examiners, assume that looking at multiple scenarios is needed to look at multiple skills that are being tested in the OSCE. But then I realized that since the purpose of OSCE is to look at skills and not at knowledge, the same scenario for different skills could very well be used. So unless I'm mistaken, I guess I am sort of answering my own question.
No,
Thank you.
I think, sir, you are absolutely right. It is objective, structured, clinical examination. So it has to be a clinical, it has to be an activity. It cannot be simply the theoretical questions. So that's why we make sure that each component of integrated OSCE, although there might be some theoretical questions, but there is at least one activity during that station. So the clinical aspect is maintained. Dr. Farhat Bashir, please.
Assalamu alaikum, sir. So my
Walaikum
question
assalam.
is that does the integrated OSCE start at the station number 1 only? For example, if the integrated OSCE has 5 stations, can 5 students simultaneously start?
No, it has to start with the station 1, and then students have to follow through because these are interlinked stations. We cannot start a student from the second or third station. To cover that, what we have, for example, we have 5 integrated OSCEs. So we can start 5 integrated OSCEs, each set of OSCEs together. So 5 students, for example, can go at the same time, and then they can rotate. But you are absolutely right. Like in traditional OSCE, we can because each OSCE is fragmented, is separated. So all the students can start at the same time. But integrated OSCE, it must start with station 1 and then follow through. So in that,
sir, it would take a lot of time if we are covering, for example, 300 students.
because the here you have, let's say, if you have 5 or 6 integrated OSCEs, and each has, let's say, 4 or 5 stations, so it would definitely take longer time than the traditional OSCE. Definitely it would take. But what we do is that because in traditional OSCE you might be using the multiple circles, right? So in this case we can have, let's say, 5 or 6 integrated OSCE and each its own circle. So, but you are absolutely right.
Thank you, sir.
It would take longer time than the traditional OSCE, definitely. Yes, Dr. Imadul Haq, please. Yes, Dr. Imadul Haq. Maybe we can start with Dr. Buchra, please.
So I need little bit clarification in the marking sense.
Right.
In integrated OSCE, it seems to me that the marking of one station can affect the marking of other stations. For example, if the student is forget to ask something in the OSCE in history taking station, so maybe he forget to perform that similar point in the physical examination as well. So isn't it that the marking will be affected because of this?
No, it wouldn't be, because the each station is although linked but still independent. For example, in the example I gave about the Uni-disciplinary OSCE, the first station student take the history, and the second station is student is asked to assess the degree of dehydration. So the so it is a clinical skill, and student has to use the same parameters to assess the degree of dehydration irrespective of the history. So, but the point is very, very important, and we have to make sure that the each station is independent, and that doesn't affect. Where it affects, for example, you can say, okay, student has assessed a mild dehydration, but the patient has a severe dehydration, and that would affect the calculation of fluids. But at that point, the examiner would inform the student that this patient has a severe dehydration, because we cannot penalize the student twice for the same mistake. Student has been given a less marks on the previous station because of the wrong assessment of dehydration. So subsequent station, we will provide the right answer for student to calculate. So in this way, we can cover that aspect. I hope that answered your question. Dr. Rajeev, please.
Sir, good afternoon.
Good afternoon.
I just want to know whether the assessment is only formative and integrated, or can it be made summative to us?
Basically, we are using for summative assessment, but of course can be used for formative assessment as well.
But what I saw, the assessment sheet was only yes, no, yes, no. No
Sorry?
marks.
No, I'll show you I couldn't show there, but I'll show the sheet. Let's see if I can show the sheet here, the mark sheet. Just give me
sure,
a minute.
Because in traditional OSCE, we make a rubric, and based on the rubric,
it is rubric. It is still a rubric, but
okay.
it uses a range of marks. Let me show you.
Yeah.
Yeah, this is let's say the market. Is it visible?
Yes, sir.
Yeah. So we have the rubrics, and then there is a satisfactory performance, less than satisfactory performance, and unsatisfactory performance. And then at the end, we have the global rating. So it actually covers that aspect. So, so this gives examiner the more liberty in giving the comments about the performance of the student. Right. Okay. Right. Okay. Next. So Dr. Rajeev, I hope I answered that. And
thank
then
you, sir.
Dr. Anila Jalil, please.
Assalamualaikum, sir, and thank you for such an excellent presentation. I have few queries. These for each station you have 5 minutes. So would 5 minutes would suffice for the student, because they have to, for example, taking history taking, say they have to ask the questions and they have to, elaborate on it. So 5 minutes would be enough for the students, because they have the anxiety factor also at that time.
Yeah, Dr. Anila, that is just an example. Okay. Yeah. But basically, what we do is, when we are doing the vetting, that is one important question we ask. The committee would ask: is it possible to complete the task in 5 minutes? So it is. So we can have the stations, but like following OSCE, we have to have the same duration for each station. So you can have 6 minute station, for example, if you find that your tasks would need longer time.
Okay. Another query is that for example, if that you gave the example of diarrhea and gastroenteritis, so that would limit the students to only one area. And if you have 6 supposedly interactive stations, that would be resource intensive, and that would be the faculty should also be trained for it to make such things for the examiners also, for the examinees also, for the rubrics also. And it's quite resource intensive, and faculty training and development should be required for that.
Madam, all the things which you have mentioned, we are already preparing for the traditional OSCE.
Yes.
All those things are, so it would not be an additional burden. But on the other hand, let's say if you have, let's say 5 integrated OSCE, one comes from pediatrics, one medicine, one from surgery, maybe one from orthopedic or psychiatry. So in a way, you are testing across the disciplines, and each case you are testing in detail. But having said that, we must realize and remember that it is not the only component of examination. So OSCE is concentrating on clinical aspect. There would be other methods of assessment being used as well.
And one more, my question is that, can it be replicated in the basic sciences?
It can be, but it would be really a bit difficult and more of theoretical. I mean, you can start with something with anatomy and then go on to physiology and biochemistry, and but it may not be as effective as in clinical.
Okay.
Because I think if we do in the basic sciences, more of a theoretical component would come in.
Right.
I have tried to develop some basic science integrated OSCE, but I really find it difficult to do that.
Okay. Thank you so much, sir.
Okay, Dr. Anshu, please.
Good afternoon, sir.
Good afternoon.
I really, you can say, got so much of information on iOSCE. I was not aware of this concept, frankly speaking. I only knew about OSCE, and but sir, what I could get from this whole of the concept, is it not a kind of, you can say, modification of long case, that we have objectified whole of the presentation of a one long case concept?
Absolutely right. Absolutely right. That's the way it is. That's the way it is.
Then can't we use the traditional case just by objectifying it rather than creating so many stations?
Yeah, yes, you can do that by objectifying, but it would not be practical. Basically, the advantage of integrated OSCE is that we are taking advantage of long case as well as OSCE. So we are taking advantage of both good aspects of both sides. To begin with, the OSCE, the traditional OSCE had replaced the long case and short case completely. And we have always felt that we have lost actually very important areas of student assessment, which we do in long case and short case. And now I'm so happy to get this integrated OSCE that I can assess long case and also taking the good attributes of OSCE. So it's actually marriage of the two. You are absolutely right.
So one more question, like you were saying at end of each question, there was that question by examiner and judgment by the examiner. Right. So is it again not adding that subjectivity part which we were trying to address with this OSCE?
Madam, here the question is fixed and the answer is given there. And because the information is provided, so the correct answer is given there. So it reduce. I mean, you can never get away with the objectivity, but it would definitely reduce to a significant degree because the model answers are there and checklist is there.
And thirdly, sir, like multidisciplinary, you are saying normally whenever there is summative assessment, there is a team of examiners in one discipline.
Right.
Then how to go with these kind of multidisciplinary, whether we will be calling experts from other discipline or it is okay that we can only assess?
No, let's say the example I gave for obstetric and pediatrics. So it would be the obstetrician would be sitting at the ONG stations and pediatrician on the pediatric station. Where it is combined, the two examiners may discuss and they may agree, because it would not be possible to have so many examiners for each examination. So one examiner at each station would be enough. Yeah.
Okay, thank you, sir. Thank you.
Right. Yes, sir. Professor Rashid Saab. Okay, maybe let's start with Dr.
Yes. Now, can you listen,
Yes.
sir? No?
Yes, sir.
Right.
Yes, sir.
Yes, thank you. Sorry, I was muted. Sir, thank you very much for very enlightening lecture. My question has been asked in different words and has been answered by you in different words. I just want to have a comment on long case and the OSCE. The one of the issue with OSCE is whether integrated or whatever it is there's the time limitation. Now, in the long case, when we are free of time, the students, they can recall, they can have sufficient time. Even examiners, sometimes they need a break and they have to think. And many questions arise from discussion. So the objectivity can be maintained, but the time limitation is sometimes affecting the student performance. Students are in too hurry to answer. They think that time will elapse. So do you think that long cases, they do have some importance?
Okay, sir. There are two aspects. Even for long case, we have a fixed time. Although it's a longer time, but still it is a fixed time, so we cannot go beyond that time. Second, when we are designing these OSCEs and vetting these OSCEs, we make sure that the task is manageable within the given time. And if you think that most of your tasks take more than 5 minutes, you can have a 6-minute station or 7-minute station. And so the second is that the task is so specific that student has to straight away go to that task, and they do not have to worry about other things. Of course, as I mentioned, there would be stress. It is a stressful way of assessment. Problem is there. No denying to that. The student would definitely be under stress. Yes, Doctor. Sorry, it's yes, Dr. Iqbal Dogar Sahab.
Thank you very much, sir, for enlightening on iOSCE. I have two questions. One is, what is the difference between interprofessional OSCE and this integrated? Are they same? And number two, my question is, how we can give one example of how we can take OSCE in radiology, iOSCE in radiology?
Okay, the interprofessional is same as multidisciplinary. Interprofessional means that there are more than one profession involved, and multidisciplinary, so it is the same. Now, as far as radiology is, I think it would be good to include radiology in different questions rather than having a complete integrated OSCE on radiology. Radiology would be best tested in multidisciplinary OSCE, where let's say one or two stations are related to radiology. So that would, because you want to test radiology in context. And integrated OSCE provides and context. There is a history of the student, physical examination of the student, and investigation. So in investigation, radiology would be included, and I think that would be the best way of assessing radiology in this format.
So should we show the films, the CT scan, X-ray, ultrasound, or MRI films, or how we should conduct this?
No, I mean, apart from the films, the soft copies are available. So if you want to use soft copy, you have a computer and you can show the soft copies there. But of course, if you want to use hard copies, still can use there.
Okay, thank you.
Thanks. Right. Dr. Muhammad Abdul Al-Wahab, please. Al-Wahab.
Okay, Assalamu alaikum. Thank you, Prof. Alam. My question, I'm not sure if you already answered or not. What if the students give the wrong answer in the first station? How to assess the next one?
Yeah, so they if they give the wrong answer at first station, they would be penalized on that station, but not on the rest of the stations. For example, in the one I showed for Uni-disciplinary, if they make a mistake in the history taking, so they would be penalized on station 1, but station 2, they are asked to do the physical examination. So they would not be penalized. In fact, this is good as compared to long case, because in long case is the same examiner. So if student does not perform well in one component, the examiner gets biased and penalized in the other parts as well. So here each station is independent, and the marks in one station would not affect the next. Please, please mute yourself. I hope I have answered your question.
Thank you, Prof. But my issue, if the patient missed the correct approach for the integrated OSCE from the first stations, can we still assess the next stations as isolated stations? I mean, if he missed the first one, for example, the case is ingrowing nail, not diabetic. So still we can assess the next station in separate approach.
Yes, because let's say the first station is history taking.
Yeah.
Second is physical examination. So even if the student has not asked the right question, still they can do the physical examination. And then in the subsequent station, some of the information may be given by the examiner to bring back the student to the right track. So although these stations are interlinked, but still they are independent, completely independent.
Okay, so we can guide the student for the next stations?
Yes, because they have been penalized on the first station, so second station they can be guided.
Okay. Thank you, Prof.
Yeah, thanks. Yes, Dr. Vidya, please.
Hello, sir. Thank you very much for the session.
All right, thank you.
Sir, my question was...
Just a minute. Dr. Aditi, please mute yourself. All right. Yes, Dr. Vidya,
sir.
please. Yes.
So my question was, we need not have an observer in each station, correct, sir?
Yes. There is option of static station. Yes, when the observer may not be needed, but that would not be an ideal situation, because we need students to do some kind of activity. Being a clinical examination, there should be some clinical aspect or some clinical procedure being performed.
Yes, I agree. That's the reason we have a lot of deficiency of staff over here. So
Right.
what if we incorporate videos, I mean, video assisted assessment in some of the stations, so that probably we can assist the child, plus we can even meet the deficiencies?
Yes, we do use videos. That is a good way. For example, we use videos of showing different kinds of fits and ask students to describe the fit and define or identify the type of fit. We do that, and yes, those kind of static stations can be used. Yes.
No, what I was telling was live streaming of the patient and the student. So how to exactly, for example, examination of the patient. So if it is live streaming, yeah, we can monitor him and then he can do the examination there. There need not be an observer sitting over there.
Yes, if you are observing by sitting somewhere else, but still you will need somebody to observe that. So yes, the examiner may be sitting in a different room, but still needs to
have
the
a
examiner needed to
person there.
observe that.
Yes, you're
Yeah,
right. Correct, sir.
Right. Okay.
Thank you, sir.
Thank you. Dr. Uma, please. Dr. Uma. Okay, Dr. Laikuzaman, please. Okay, Dr. Aisha Iqbal.
Thank you, sir. I have a question. You just mentioned that for integrated OSCE, you would prefer it for summative assessments.
Right.
Like the major concern for me is that if we introduce integrated OSCE in summative assessment, so what about the reduced number of stations that would be offered to each discipline? Because usually we conduct OSCEs for each individual discipline, and each individual discipline has 12 to 14 stations to assess.
That probably can be done in the rotation. But
like end of clerkship rotation?
End of clerkship rotation. When it comes when you see ideally the number of stations should be around 18. 18 to 20 stations is enough to have a reliable and valid assessment. So by, let's say, using 5 integrated OSCE, we already have around 20 plus stations. Now, the other point is that the summative assessment at the end of 5 years, the objective is totally different. We are not looking at individual disciplines, but we are looking at the suitability of a candidate of being a house officer. So we are looking at different aspects. What you are saying is end of clinical rotation. Yes, you can have 10 or 12 stations. This means that 12 stations, you may have 3 different sets of integrated OSCEs, 3 different cases. When coming to summative assessment, I think if we have 1 integrated OSCE, that means 4 or 5 stations for each discipline. That should suffice the criteria for summative assessment.
Thank you, sir. So it means you're suggesting that the scores from end of clerkship rotation could be carried forward as part of summative assessment.
That's right. That would be part of continuous assessment.
Thank you. Thank you, sir.
Right. Okay. Right. Okay, Dr. Umas, please. Okay, let's say Dr. Kishwar. Dr. Kishwar, please. Dr. Kishwar Nahid.
Thank you very much, sir. First, for enlightening us on a new assessment tool. Sir, my question is that possible that we can add the fragmented OSCE plus iOSCE, like 3 or 4 stations for the integrated OSCE, and 3-4 we can add as a fragmented OSCE, our traditional one?
Yeah, I mean, to begin with, you can do that, because when you are starting, for example, integrated OSCE, you are moving from one to another aspect. So that there may be a learning curve there. I mean, the traditional OSCE has its place, although, excuse me, I have mentioned some of the drawbacks, but you can still have a combination of the two. Yes.
Okay, thank you very much, sir.
Okay, Dr. Irene Parveen, please.
Assalamu alaikum, sir.
Walaikum assalam.
I am from Bangladesh.
Right.
What is the difference between interactive oral examination and iOSCE?
Right. Integrative oral examination is mainly the viva. So whereas OSCE is a clinical examination. So integrated OSCE follows a patient through at all the different stages. Whereas what you are saying is mainly what we used to call viva OSCE with the structured questions. And you can say that integrated OSCE is a combination of 4 or 5 integrated oral examinations.
Okay, sir.
Right.
In our country, in FCPS examination, interactive oral examination start where OSCE station are reduced and there are 5 interactive oral examination. There is successive question like this interactive OSCE.
Yeah, but as long as it is the same scenario being followed and there is a clinical component, so that would change your interactive oral examination into integrated OSCE.
Okay, sir.
All right. Okay.
Samim, sir.
Walaikum
Sir, what
salam.
is the difference between thematic OSCE and iOSCE?
The thematic OSCE, you can say, because thematic OSCE is again following a theme. Right. Now, in thematic OSCE, if you are following a theme, you may not have the interrelated stations. You may have different aspects of a theme in different stations, but there would be very fine difference, if any. Otherwise, for example, here is our overarching objective is assessment of a student in regards to let's say, degree of dehydration and acute gastroenteritis. So the thematic OSCE would have, you have a theme and all the OSCE stations are following that theme. So would not be a major difference between the two. I hope I answered your question. Okay, Dr. Chimney Shah, please.
Sir, good afternoon. Just I would like to ask that we are using, sir, OSCE since many years.
Right.
But what problem we are facing that if student is missing an important point in the checklist,
right?
What to do? Because always external examiner say that OSCE is not perfect because he has missed this point and then also he get passed. So can we give negative marking or do we have any other mechanism how to take care of important point in the checklist?
No, that's very, very important question. What we do is that when we make the checklist, we make certain points must know. So
okay.
the things which you think are very, very important, so we make them as must know. So if student does not answer that, so that obviously they wouldn't get marks for that. And they cannot replace that must know with the other information. So let's say if I have in the checklist, there are 10 points and 5 of them are must know. So I would expect the student to definitely answer those 5. And the not must answer would not actually cover for the must answer. So that's one way of handling that.
Okay, sir.
Yeah, thank you. Yes, Dr. Umar. And our Dr. Vidya, Dr. Vidya. I think they.
Thank you, sir. You answered my question. Thanks a lot.
Thank you. Right. I think that's. I have answered all the questions which people have raised their hand. If there is any other question, I'm happy to answer that. Yes, please.
Sir, if we make it integrated OSCE in summative examination, we will not cover all objectives in different disciplines. So I think we have to cover in summative also, as well as formative assessment also.
Yeah, we can definitely
continuous assessment.
Yeah, definitely we can do that. Definitely we can do that. If you have end of clinical rotation integrated OSCE, so that those marks can contribute to the continuous assessment. Definitely, yes.
Otherwise, we will not cover all objective of all disciplines. So number of stations will be more. Everything will be more if we do it in summative assessment.
Basically in summative assessment, we normally concentrate more on major disciplines. But if we are doing end of rotation and using those marks as continuous assessment, that would be a better option.
Yes, sir. Thank you.
Okay. Thank you very much, everybody. I have to just share one last slide with you. And that is this slide, which I usually request that
please.
Yes, please.
Sir, I want to ask just as previously also somebody has asked about the deficiency of staff at the OSCE station.
Right.
And you were saying that you are doing with video.
Right.
So how you are doing? I mean, how managing it? So please tell us.
So the video station would be a static station where there is no examiner. The video is being played, and then a question is there which student has to answer. The example I was giving, let's say video of generalized tonic-clonic fit. So video is played and student is asked to describe the whatever they see, and then they can be asked to identify the type of fit this patient is having.
So they have to write? The students have to write?
Yes, they have to write the answer, yes. That is not an ideal station, but that is an example of a static station.
Thank you, sir. Thank you.
Right. So at the end, I thank you everybody for your participation, and I just want to make this appeal. Somebody please mute yourself. Yeah, so I just want to make this appeal, which I make at the end of every webinar. May I propose to each participant to donate $1 USD or equivalent amount in your local currency to any deserving individual in your neighborhood or any public welfare organization in your community after attending every webinar conducted from this platform. That is just a request or a proposal. Thank you very much, everybody, for your cooperation. I will be sharing the video recording of this session in due course of time. Thank you very much.
Thank you, sir.
Thank you, sir. That was great.
Thank you very much, sir.
Thank you.
Thank you.